So we'll have Dr. NEENA R for diplopia after cataract surgery, when binocular vision becomes a bane then a boon.
So a warm good morning to one and all. So my paper is on diplopia after cataract surgery, when binocular vision becomes a bane rather than a boon. So I have no financial disclosures. So we know that cataract surgery is the most routinely performed surgery in modern ophthalmology, the results being extremely spectacular, and patients and the surgeon have high expectations. So when a patient develops diplopia post-cataract surgery, it is a source of major distress, not just to the patient, but a source of big surprise and disappointment to the operating surgeon. So the aim of my study was to evaluate the causes of binocular diplopia following cataract surgery. So this was a retrospective electronic medical records analysis of all those patients who complained of binocular diplopia within 6 weeks of cataract surgery at a tertiary eye care center in South India from 2015 to 21 with a minimum follow-up of 1 year. We excluded all cases of monocular diplopia due to lens implant decentration or subluxation. Spontaneous resolution of diplopia within 4 weeks of onset was also excluded, and all cases of fleeting diplopia were also excluded. So these were the parameters we studied. Apart from the demographic factors and the type of cataract surgery, eye and anesthesia, we analyzed the details of the diplopia, binocular vision and squint evaluation, ocular movements, systemic and ocular comorbidities in detail. We also analyzed the interim and definitive management strategies for diplopia. So we had 38 patients in total, 30 males and 8 females, with a mean age of 72.4 years. All had an uneventful cataract surgery. 36 patients, that is about 95%, underwent phacoemulsification, and the rest underwent small incision cataract surgery. Peribulbar block was used in all patients. So what we found that there were pre-existing diplopia cases in 21 patients. That is 65.79 patients complained of diplopia even before cataract surgery. New onset diplopia was seen in 13 patients. That is about 34.21%. Diplopia was missed. We later found it out, but it was pre-existing. It was missed in about 10.53% patients. And the most common type of diplopia was horizontal, followed by vertical, and one patient had a combination of both. Surprisingly, 73.7% complained of diplopia on looking to the operated eye, assuming the cataract surgery to be the causative reason or the cause of the diplopia. So coming to the binocular vision evaluation, pre-operative Würzwood or test for distance was able to detect diplopia in about 42% patients. Pre-operative squint evaluation picked up squint in 21 patients. Diplopia charting preoperatively detected diplopia in 20 patients. This we were able to do because majority of the patients in our study had a best corrected visual acuity of better or at least 6/60 in the worst eye preoperatively. Coming to the etiology of the diplopia, what we found out was that most cases of pre-existing diplopia were decompensated foria to tropias, basically tropias, exotropias mainly, and most of the new onset diplopias were cranial nerve palsies. So you can see here, most of them were decompensated forias to tropias and cranial nerve palsies. There was one patient each with ocular myasthenia, local anesthesia-induced diplopia, post-scleral Burkill-induced diplopia, and post-traumatic diplopia. Coming to the cranial nerve palsies, most of them, that is 72%, were ischemic mononeuropathies. 5 patients, that is 28%, had neurological associations in the form of cerebrovascular accident, keratico-cavernous fistula, and hepatic encephalopathy. Among the ischemic mononeuropathies, the most common was superior oblique palsies, followed by lateral rectus and third nerve palsy. Decompensated tropias, the most common was exotropias and followed by a small fraction of esotropias. In the interim management, 50% patients, that is 19 patients, opted for prism glasses. 4 patients each opted for monocular occlusion and orthoptic exercises to get rid of the diplopia. The patient with ocular myasthenia gravis was treated with pyridostigmine and oral steroids. The rest opted to a wait and watch policy. So these are some representative pictures of patients who are rehabilitated with prism glasses in the interim period when they were waiting for recovery. One patient of intermittent exotropia to right exotropia and a patient of superior oblique palsy of the right side. Coming to the definitive management, 71% patients eventually had relief from diplopia. 15%, that is about six patients, they made spontaneous recoveries. 9 patients had to undergo squint surgery to get binocularity back. 11 patients continue to use prism glasses, and 1 patient had to have prism glasses even after surgery to get rid of the diplopia. And 29% patients did not take any treatment, and they decided to still wait. So this is a surgical correction video of a patient who underwent exotropia correction. This lady, she had a large left exotropia, which was there preoperatively, and then eventually she landed with intractable diplopia post-cataract surgery, and we had to do surgery to correct her squint as well as to get her alignment back. And this gentleman with left superior oblique palsy also had to undergo inferior oblique recession to regain his binocularity. So coming to the discussion, out of the 48,500 cataract surgery files we scanned from 2015 to 2021, we could get records of only 38 patients, that is 0.078% with binocular diplopia post-cataract surgery. Even though this number appears minuscule, it is significant because it produces a lot of distress to the patient, and these results are comparable to the study by Costa et al., in which he scanned 20,453 files and could get only 19 files, that is 0.09% incidence of post-cataract surgery diplopia. They used a retrobulbar block, and whereas we used a peribulbar block. So uneventful cataract surgery, still patients attributed diplopia to the cataract surgery. And the funny thing is, majority of the cases of post-cataract diplopia were pre-existing, mainly decompensated tropias. So new onset diplopias were rare, local anesthesia was rare, and pre-operative binocular single vision examination picked up majority of the diplopias in our cases. And to conclude, what I would like to say is that diplopia after cataract surgery is infrequent, but a source of great discomfort. A basic binocular vision assessment, including Hirschberg, Würzburg test, a cover test, and a diplopia charting will pick up majority of your preoperative diplopias, and it should be made part of an integral part of your examination. And patients with preoperative squint and diplopia should be counseled for chances of postoperative diplopia and the possible need for prism or surgical correction. Thank you very much.
Yes, Dr. Neena, I just have some doubt. Like your cranial nerve palsies, how soon was it detected in the post-operative status?
That's what, the glass appointment. That is, most patients would complain of diplopia only at the time of glass appointment. That would be like 2 weeks from the surgery.
Yeah, but these are new onset cranial nerve palsies which developed immediately after the cataract surgery.
Not all. So that's what I'm saying. We had pre-existing cranial nerve palsies also. Some of them were decompensated congenital superior oblique palsy. Some of them were new onset. But that we were able to analyze retrospectively when we asked them for pre-existing, that they ever saw double and that they had a head tilt. We analyzed their pictures. Some of them were recent onset.
Yeah, so with regard to the recent onset cranial nerve palsies, what was the etiology in those patients?
Yeah, so the systemic risk factors were seen in about 36 patients, with more than 19 of them having multiple risk factors like diabetes, hypertension, hyperlipidemia, and coronary artery disease.
Yeah, why I'm asking is because all these would be well controlled for the cataract surgery. So when you are giving the fitness for cataract surgery, we see the diabetic and hypertensive and all these status. So it is very surprising that after that it is.
Yeah, but what I have seen in my practice is that even if you have a very well controlled diabetes, hypertension also, the patients, the long duration of the disease sometimes is highly predisposing to an ischemic cause. And a cataract surgery could be a stress. So that adds like a stress to the development of probable. It's my theory.
Another thing is all the cataracts were operated under peribulbar block, even though they were not a mature cataract.
No, that's what all in our study, all were under peribulbar block.
So it didn't happen in topical cases?
No, this series in which from 2015 to 2021, all were peribulbar blocks.
Okay, thank you.
Dr. Neena, a lot of very useful data. It's a very good study, but I think we need to probably probe more into. We can probably get more outputs out of this. But one thing is the common place is the patient develops a mature cataract. So aphoria breaks down into a tropia. This is very common. A lot of people come with mature cataract with exotropias. So out of your 38 cases, how many of them fell into that, and what exactly happened? When you operate them, some of them will have diplopia in the beginning, they settle down. You had a lot of spontaneously improved diplopias which you took out from the study. Maybe that would have been a very good arm to study, because
Yeah.
that is a common place. A lot of people who have straight eyes develop cataract in one eye, develop exotropia when they come back. So we will be in a dilemma to know whether the patient will have a post-op diplopia or will have straight eye. Some of them will miraculously have straight eye on day one. Some of them will continue to have exotropia. Some of them would have decomposed so much they will never come back. They will have to be treated like a competent squint. So maybe that would have been a very good take-home message. And in that situation, with the experience of your study, because every study finally has to add something to the literature. Otherwise, there's no point doing a study. Something has to get better after your study. So, to the audience, what do you want to say? Like, if a patient who had straight eyes develops a mature cataract, develops an exotropia, when he comes back, what are the chances that he will continue to have that squint with diplopia? How many will probably straighten out soon after surgery?
We actually tried to look into it, but because it was a retrospective study, we really couldn't get the duration. Actually, the duration of the cataract, how long they waited before some patients get one eye operated and they don't do the other eye. So those were the patients which I thought developed exotropia, because they waited quite long till the cataract in the other eye became very bad and then went into surgery, and most of them had exotropias. So I actually wanted to see the duration, but because it was a retrospective nature, I couldn't really correlate it with that. The second
If you can look into that, what you excluded, you can
Yeah.
take that term and study. That would be a very useful thing. Because anyway, this rest is all because you have a very heterogeneous group of etiologies here. But that would be a very common dilemma for us. Like, what will you tell the patient? Will the patient require a squint management post cataract or not? Will the patient you create a new problem of diplopia when patient is already monocularly?
Yeah.
So that is something that we
Yeah.
would like to
So
know.
what I usually tell is, if any cataract surgeon sends to me pre-operatively a patient with squint, and if I check and I note that if I ask them, do you have binocular diplopia in day-to-day activities? Then if they complain of binocular diplopia, I tell them there could be a chance that you could have post-operative diplopia, which you might be able to sometimes manage on your own. Otherwise, you may require some intervention. And then the younger the patient, and if I'll see if the patient is just above the age of visual plasticity, because we had one patient in the age of 40 years who just couldn't fuse. He was a high myope. He had undergone femtose laser cataract surgery and landed up with intractable diplopia. So maybe patients with a little bit of unable to totally suppress the image, but at the same time they had useful near vision earlier, those were the patients who were more likely to have postoperative diplopia.
In our experience, mostly we have seen this happening in patients with mature cataracts, where they decompensate fully, like Sir said, and it goes for an exotropia. So one thing is, patient will not complain of diplopia preoperatively. So because the cataract is mature, so we don't know whether it is a pre-existing exotropia with the cataract added on, or it's a decompensated exotropia. So one idea is to go back and look at old photographs, or just get a history if possible, because if it is a late onset decompensated XT, then there is always a chance of double vision in the post-operative status. So that's how we explain the
But we
patient.
didn't have many matches, because our visual acuity, all of them had, majority had better or at least 6/60. Only 5 patients had vision less than CF 3 meters.
That's why I said it's a this data is very, very unique. Maybe we need to go deep into it to get better outcomes. Okay, thank you,
Thank
Dr.
you.
Neena.